Hello and welcome to this session for expert on oncology for a panel. I hope you had a good lunch in the sun of London. My name is Olivier Lucas. I'm the Director for Oncology at Oxford Nanopore. In this session today, we do have 4 distinguished speakers. I know on the agenda you have 5, but unfortunately Helen Belbeck couldn't be with us today due to a last-minute change. So the speakers will, one after the other, give a 5-minute introduction to their area of work. No slides. This will be followed by the panel discussion. There we will aim to explore the future challenges and potential opportunities to fully realizing the power of genomic sequencing to improve human health. We'll be taking questions for the panel from the app and from the floor. If you use the app, remember to use the thumb up icon to upvote your favorite question. I do encourage you to consider questions for the whole panel. However, if you have a question for a specific member of the panel, do make sure you start your question with their first name. Now, I am delighted to welcome our first panel member, Dr. William Stanford. William is a physician scientist whose practice, the Beverly Hills Institute for Precision Medicine, provides multi-omic precision medicine consultation for the primary care providers and their patients. William is also co-founder and chief medical officer at Biography Health. It is an online platform for the aggregation, analysis, and reporting of multi-omics health information. He completed the MD, PhD, and internal medicine residency at UCLA. And he has practiced hospital medicine for 15 years at Cedars-Sinai Medical Center in California. William?
Thank you, Olivia, and thanks to Nanopore for the invitation. It's really a pleasure to be here to talk to everyone today. So a little bit of an echo there. Our practice in Los Angeles involves research around personalized precision medicine. So the usual scenario is that a patient will go to their primary care provider and they'll be concerned about family members that have certain chronic diseases, and their question is, have I inherited that risk? Is this something I should worry about? And many of the primary care providers in Los Angeles know that I'm there to do this personalized precision medicine analysis. So when we get the patient in our office, we do a very deep dive into their past medical history. We look at their extended family history, first and second degree relatives, mom, dad, brothers, sisters, grandparents, aunts, uncles, whole thing. We get a consent to obtain their medical records, and we get our hands on everything we can get our hands on. So imaging, biochemistry, usual labs. At the same time, we do collect a saliva specimen for whole genome sequencing. Unfortunately, the way things are right now, and Nanopore is going to fix that, is it takes 4 to 6 weeks to get that VCF file back. And we get that VCF file run through polygenic platform that can generate polygenic risk scores. Polygenic risk scores are those SNPs that don't have the disease penetrance of something like BRCA or CHEK2 or something like that, but they in themselves do carry relative risk, and when you look at them in summation, they can actually have quite a substantial risk. So you layer onto that clinical factors. I'm going to use an example of breast cancer. So we know that there's a lot of clinical risk factors: smoking, diabetes, body mass index, have they had a mammogram, breast density, first and second degree relatives with breast cancer, when they started their period, have they had kids, all those kinds of things. So when you layer those clinical factors onto the polygenic risk score, you can generate an integrated risk score, which can be quite predictive, or we feel can be quite predictive of the patient's future risk of chronic disease. So again, in the case of breast cancer, you have the monogenic risk like BRCA, et cetera, and that picks up that 1 in 400 people that carries that risk. But what about all the other people that are getting breast cancer and it appears to have an inherited pattern. Well, those are the people that we're picking up. And so why is it so important to pick them up early? Well, because some of those risk factors are modifiable lifestyle factors, and you also want to bring them to the attention of a high-risk clinic. So there's several high-risk genetics breast clinics around LA that we can refer patients to in that instance. Because the idea here is you want to detect that transition from health to disease. First, you want to delay or prevent it if you can. And if it does happen, you want to detect it at early stage when it's easier to treat because of less tumor burden, not metastasized, less mutational burden, higher cure rates, or higher survival, and better outcomes. So in a nutshell, in summary, deep dive into the person's past medical and family history, really look at who they are, individualize them, look at their polygenic risk, fold in these clinical risk factors, identify people at high risk for closer scrutiny, and then people are at lower risk for certain chronic conditions can get standard treatment and screening. And if you can detect these patients in transition, you're going to have better outcomes. Looking toward the future, if we can do DNA sequencing along with methylation sequencing and develop methylation risk scores to fold in, it's going to be even that more powerful. Thank you.
Thank you so much, William. Before I introduce the next speaker, please remember to submit your question through the app, and we'll take the question at the end of the presentation. So now it is my pleasure to introduce our next panel member, Dr. Clemens Jacobi. Clemens is a Senior Director for Commercial Development in the mRNA business unit of Lonza. In his current role, Clemens is driving forward growth project in the area of mRNA modality. Together with a team of experts at Lonza, he is developing an mRNA manufacturing platform to enable an agile response to unmet clinical needs. Clemens?
Thank you so much. So the most important things are what is not said. So I'm a pharmacist by training, and my job is to manufacture the drugs, amongst others, for oncology. So that is why I have a question to the audience, and please, the panel is not allowed to respond. Who in this room knows what was the first antibody, monoclonal antibody, approved by the FDA for the treatment of an oncology condition? And when was that? Anyone in the audience has an idea? And sorry, excluded. So we have already the right answer. It was Mabtera or rituximab. Do you know when it was? So that is easy. I had to look it up as well, but not now, because when I did it, it's the same year when my daughter was born. It was 1997. So in 1997, and I put that at the beginning of the short words I say, that is not so long ago. Today, we are treating patients with antibodies. That is the standard of care for most cancer types. We are today already linking the antibodies to certain payloads, and this is then drug conjugates. So there are a lot of kind of modalities based on this technology. And maybe I do a poll in this room. What do you think? When you treat breast cancer, is breast cancer treatment related to genetic testing? Who believes that any breast cancer therapy today requires a genetic testing? Can I see hands, raise of hands? Who believes that when you treat breast cancer, you do not have to do genetic testing? That is interesting. Why? Okay. So, so today, when you're doing breast cancer treatment, it is almost a standard of care that you do a genetic testing. There may be cases where you don't do that, but it's almost in every case. So when I look back, when I started my career in manufacturing, when I did QC testing for erythropoietin in manufacturing, genetic testing was not where it is today. And when I look in the time scale where we are today, and when I'm here now at London Calling and see what Oxford Nanopore is doing, this is mind-blowing. Just imagine us presenting what we know today 30 years ago. It's mind-blowing. What we can do now, this is so fantastic. And I'm here today to talk with you about the potential we have with all the genetic testing in order to treat cancers appropriately, but also manufacture drugs which are targeted for patients, including but not limited to the mRNA treatment. Thank you.
Thank you, Clemens. Quite exciting and intriguing for the discussion. Please remember, keep your questions coming using the app, and we'll use it in the panel discussion. Now, I'm delighted to welcome our next panel member, Dr. Luca Mazzarella. Luca is a physician-scientist who specializes in medical oncology in Milan. He obtained his PhD not very far from here in London at Imperial. Currently, Luca runs the Laboratory of Translational Oncology at the European Institute of Oncology in Milan. There he focuses on cancer genomics and bioinformatics across multiple cancers. Also, as a clinician, he has worked for several years on phase 1 trials and recently moved into gastrointestinal oncology. Luca?
Thanks a lot. Can you hear me? Yes? It's working? So actually, before talking about what I do in the areas of my expertise, I actually thought that it would be nice to respond to what you were saying, Clemens, before, because I think that one can answer to your question on how often is a patient tested for genetic in breast cancer treatment in two ways. So I wasn't sure which answer you were expecting, because in fact, genomics, it is surprisingly little used in decision making in cancer. And breast cancer is an especially important case study. So the number of mutations or genetic alterations that are useful in the general management of breast cancer is surprisingly low. And up to a few months in some countries or years ago, it was not part of the diagnostic routine. So it's only very recently that some of the mutations that have entered the clinical routine testing because some drugs have been developed that specifically target those alterations. And so I think, one element of the potential discussion for the panel, more than what I do in general, is that why isn't genomics more often used to take conventional decisions? So very often, you base your decision not on the fact that a patient has a certain genetic alteration or not, but simply because over the course of the years, drug A was tested only after in patients that had already received drug B, and therefore, in your general life, you're constrained by the fact that you can only provide this drug after the patient has been exposed to the other drug. So there isn't really any genetic or rational decision making that is based on biological parameters. So one thing that I think is important, especially in this context to understand, is that even if we are able to sequence the entire genome with long-read sequencing, obtain methylation, and obtain all sorts of fancy parameters that sort of make all the researchers very excited in the room, from the point of view of the oncologist, what really matters is what is associated with an FDA or EMA approved drug where you can provide that information to the patient in a safe network, right? Because if you go around a patient saying, look, I don't have many treatments for you, but hey, you got this really rare translocation that no one has ever observed, right? So, that patient is not going to be as excited as you are. That patient only wants to know whether there is a rationally, designed drug against his or her disease. So I think this is very important to understand. I think one of the areas where all companies like Nanopore are probably working is to try to bring all this research into the clinic, but in a way that doesn't necessarily privilege the excitement from a research perspective, or more from the regulatory perspective. Unfortunately, this is very boring, but it has to be done, because otherwise all this exciting research is not going to translate into patient benefit. So I don't know if I have time, but just very quickly, what I'm been using Nanopore for in my regular research life, we've been carrying out two different projects. One is on the characterization of HPV integration in some rare tumors. We believe this is a very interesting aspect of HPV biology that can be resolved using Nanopore, because that allows you to understand very well where the virus is integrated in the genome, how many times, and in which configuration, and the methylation status of the HPV genome and of the surrounding area. And we think that this may have some impact in HPV-associated cancer and be predictive in some way. And the other aspect is something that has been a recurrent theme at the conference these days. We are very excited at the idea of using Nanopore for liquid biopsy to detect methylation, most importantly, in a number of situations. One that we are particularly interested in is in gastrointestinal neuroendocrine tumors, which are very interesting and biologically heterogeneous entities, and we think that they are an ideal field of application for the Nanopore technology. That's it. Thanks a lot.
Thank you very much, Luca. Now I'm delighted to welcome our next and final member for the panel, Professor Matt Brown. Matt is a clinical scientist and Chief Scientific Officer of Genomics England. There he works in genetics of human disease, with a particular focus on common and rare bone and joint disease, and in cancer genomics and personalized medicine also. Matt also practices rheumatology with a particular focus on spondyloarthritis. Matt?
So thanks for that introduction, and perhaps more relevant to today's talk, I'm also the Senior Responsible Officer for our Cancer Research Program at Genomics England. Okay, so I'm going to give a slightly different talk about the Genomics England program overall in cancer and cancer research, and what it's doing, aiming to optimize cancer personalized medicine genomic medical services, particularly focusing on whole genome sequencing. I think it's important to start by saying that this is a collaborative program. So whilst GEL does quite a bit of its own research, it does most of its research in collaboration either with the NHS or with the external academic community and with commercial partners. And the program covers all aspects of genomic medical services, running through from consenting, speeding and easing consenting for research and clinical purposes, sample collection and handling, wet lab and sequencing aspects, assessing and validating new technologies for precision medicine purposes, looking at multi-omics and multi-modality approaches, and of course analysis tools. So I'm going to give examples from some of those as I expand on that. So firstly, looking at sample collection and handling. Many of you who work in cancer genomics have to work with FFPE samples. It's been a real problem for clinical cancer sequencing because FFPE interferes with amplification and sequencing technologies. And so we've done an extensive comparison of FFPE versus fresh frozen versus alternate preservative types like RNA later and PAXgene, and confirmed that FFPE performs poorly, especially for structural variants like insertions, and that RNA later actually performs equivalent to fresh frozen. And that means that now the NHS has started introducing RNA later in place of fresh frozen for whole genome sequencing and other sample types. And this is something that I think could be used worldwide. Obviously, RNA later much easier to implement in clinical services than fresh frozen with its requirement for liquid nitrogen. So I mentioned that a lot of our research gets done by enabling research externally, and in particular, we do it through collecting genomic medical service sequencing and from our 100,000 genomes and other cohorts that are sequenced in the so-called National Genomics Research Library, which some of you in the audience will already be working with. But just in case you don't, this is a huge public research data set linking patient clinical data and sequencing data. And it now has over 20,000 whole genomes from cancer patients with linked clinical data into it, with the duration of follow-up on some of these going back over a decade. We've recently done a benchmarking exercise which compared the publicly available global cancer data sets with the National Genomics Research Library, and across the major common cancer types, breast, colorectal, renal, sarcoma and uterine. It's the largest global cancer data set, including all of the other data sets put together. And for whole genome sequencing data set, for genome sequencing, it's the largest compared with all of the others together for 12 out of the 19 most common cancer types. So it's freely available to academic researchers currently. So if you're not using it and researching in cancer genomics, I recommend you come to the Genomics England websites and think about using that excellent data set. So we have a specific program developing long-read sequencing technologies for cancer, which we call our Cancer 2.0 program, and it's looking at using long-read sequencing, particularly Oxford nanopore sequencing, to try and achieve three things. Firstly, to try and make sequencing more local so that samples don't have to be transferred and processed at different parts of the country, slowing down the rate of genomic sequencing. Secondly, because the sequencing itself might be faster, and of course in some cancer types like acute leukemias, that's actually particularly important. And thirdly, because for some cancer types, epigenetic variation is of clinical relevance, most notably, for example, sarcomas and gliomas. And so this program is sequencing those different cancer types in a real-world setting in genomic laboratory hubs in the NHS. And we've done a ton of work developing sample handling pathways, sequencing protocols, and most importantly, upgrading analysis tools that have been developed in the research world so that they're now usable in clinical settings and have performance that's suitable for clinical purposes. And so this program will complete by the end of March next year, and we hope at that point that we'll have validated quite a few of these things sufficiently that they'll be considered for commissioning in the NHS, and then hopefully that will provide some support for that happening globally as well. Alongside that, we also have a multimodal research program which is about bringing together whole genome sequencing, digital histopathology and clinical radiology imaging, all in the same research environment, with the goal of actually enabling multivariate predictors of cancer behaviour going forward. That data set has over 300,000 slides on more than 10,000 cancer patients in it, which makes it now 4 times larger than the next largest data set, the Cancer Genome Atlas. It's going to be publicly available from next year, early next year onwards, and hopefully will be a really good resource for the clinical community to go out and use for multivariate analysis of cancer biomarkers and for improving cancer personalisation, cancer treatment personalisation. We're building on that by, over the next couple of years, adding, in the first place, bulk transcriptomics to many of these samples, but secondly, looking forward further into the future, adding spatial transcriptomics to it. So currently, of course, most patients will have some immune histochemistry or other pathology staining studies done, usually only for a couple of markers, and yet we have in the research land the capability of doing essentially the whole transcriptome and 5,000 or more proteins at single cell resolution level at a cost which is only a log order more than the current cost of the histopathology. And since they're actually largely sequencing enabled, that cost is going to come down considerably over the next 5 to 10 years. So we see that as having a fair chance of actually entering clinical practice and perhaps replacing current histopathology methods. So over the next couple of years, that multimodal data set is going to build up quite large spatial data sets associated with it. We're also doing quite a bit of work in cancer vaccines research programs, in particular trying to speed up the sequencing approach, because cancer vaccines require that you go from identifying and enrolling the patient in a cancer vaccine therapy trial to actually completing the genomic profiling, analysis and production of the cancer vaccine within a very short period of time, maybe only 30 days. And so therefore anything that you can do to reduce the time of sequencing and analysis is really critically important. And so for that reason we're looking at, for example, replacing exome sequencing with genome sequencing and using local sequencing to try and speed up those, because we see cancer vaccines as becoming an important part of personalised cancer care in the future. And then the last one I just wanted to mention was our diversity program. Diversity issues are generally thought of mostly to do with heritable diseases, polygenic risk scores, for example, but actually they also have a significant effect on cancer personalised medicine. It's little known that actually patients with non-European ancestry, not only do we know less about their cancer genomic profiling typically, but we've also demonstrated that the current analysis tools tend to result in biases in cancer mutation prioritization based on ancestry, and that this is a bias not caused just by insufficient data, which is part of the issue, but also the analytic tools. And so that's something we're looking to resolve. I'll stop there. Thank you.
Thank you very much. That's quite a set of different topics we just had there. So that was the idea, to assemble different experts. So it's now time for our panel discussion. At that point, we will be taking questions from the floor and from the app. But before that, I will invite the panelists to join me. So do keep the question coming as we have the panel ongoing. Again, thumbs up for the one that you want to see. So preparing for that session, we really wanted to cater to the whole spectrum, I would say almost the journey for a patient. And we thought about a few larger topics that can be discussed. So it's not like we have a question for all of those, but just to give some idea of some of the thinking that goes into planning. So what does precision oncology mean for the patient and population, as in the title? Also, if at any point you want to bring up the recent advances over the last year, I think that'd be great. What we'd like to hear overall are the challenges also in integrating genomics into mainstream clinical practice. And clearly we've already heard from all of you that it's one thing that is happening right now. And also opening up outward as what is the path forward? I mean, how do we work together? So with that, we'll be able to start to take the first question. So question can be from the audience to the panelist to panelist also. We started to see some exchanges. And we do have the Slido question also. So first, do we have a question in the audience? Yes.
Hello there. My question is for William. Great talk.
Thank you.
As we move forward on screening strategies and we adopt more parameters like methylation, PG, polygenic scores, density, etc., we tend to lose a bit in terms of specificity and detect more people that are more prone to follow a pathway,
Sure.
which requires more strict examination for more frequent ultrasonography, mammography, plus or minus MRI, for example.
Right.
So look at the other edge of the other part of the scope, which is like the patients with very low risk. Are we confident enough that we can de-escalate that?
That's a great question. That question came up at the last meeting I was at about a week ago. I don't think we're quite ready for that. You know, for example, if if someone is low risk, they still have a 2 or 3% chance. And so, at least in the U.S. in our practice of defensive medicine, et cetera, you're not going to see physicians telling their patient they don't need to get a mammogram at age 45, for example. But certainly it portends, I think, for the future, this risk stratification, identifying those at higher risk and those at lower risk. There's certainly going to be different monitoring protocols, and there's financial gain to be had by detecting the disease earlier and those at high risk. And certainly I can see a point in the future where, just by definition, there's going to be different monitoring for different levels of risk. And there should be cost savings realized in that.
So actually, just to piggyback on that and on what you said earlier, William, I mean, when you started to talk about testing, the first word you used was imaging. So I had a question, was really about how do you see going forward the integration of imaging, AI, and genomics, either or? Because, I mean, right now in a tumor board, it's going to be 100% virtually imaging. So where is genomics fitting?
Well, yeah, we talked to someone, was that you, Luca? Someone was talking about multi-cancer early detection, for example. Certainly, I would rather detect the cancer that way than detect it when it's big enough to see on an MRI. Now, having said that, with AI, as you mentioned, and also sequential imaging, there's certain programs in the U.S., so we pay for them, but where you get high-resolution imaging, MRI imaging every year. I see ultimately, and you can see from our approach in our institute, that we really believe in a multimodal, multi-omic approach. Each, genetic sequencing is one thing, but are the genes turned on or off? Is there something detectable? And then again, you can look at proteomics. Someone mentioned 5,000 proteins in a cell. There's that kind of resolution in blood as well. And all these layers of omics are going to inform the other. And you can imagine, well, actually, I don't think any of us can imagine what AI will present us with, 7 or 8 or 10 years from now. It should be crazy. I mean, crazy, what will be possible then.
Thank you. Any comments from one of the panelists, actually, because we raised a few topics there that maybe somebody want to rebound on?
Well, if I could just comment on the polygenic risk score one. I think the question was extremely apposite, that polygenic risk scores, particularly where the prior probability of disease in an individual is low, actually don't perform very well. So whether they're actually going to be of use in general population screening, I think is really quite unclear at the moment, and I think is a research topic, and hence our Future Health program in the UK, which should actually give us the data about whether they truly perform well enough to be implementable as a routine clinical service. They perform much better if you've actually got people who've got a high probability, prior probability of disease. So an obvious setting in the UK would be people who are being referred for rapid cancer screening services, where if they have low polygenic risk scores, then basically that's helpful for saying that they don't need to be seen so urgently compared with if they have high, and it would help point you in the direction of cancer that they might have. I think, though, the screening in the general population is extremely challenging, and we should just be a bit cautious about whether we think that polygenic risk scores or integrated risk scores, combining polygenic risk scores with other modalities, are actually going to work until we actually have data to show that at a population level.
Can I make a comment on this?
Sure, Luca, sure.
Because I think I was having a discussion on polygenic risk scores within an European group I'm part of with Andres Metspal, who's a big proponent of the PRS, who's Estonian. And I think one slightly overlooked aspect of this is that whether PRS or any genetics-based prediction score is going to be useful in the population depends a lot on the population. So if you have a small and genetically homogeneous population like they have in Estonia, then most likely it's going to be good. But if you have a highly diverse and very large population, as you have in the UK, and with all the issues on diversity and ancestry that you mentioned in your talk, then of course the likelihood that PRS, a generalized application of PRS to the population, the likelihood that this is going to be useful is much lower. And of course you cannot really say, okay, first we identify whether you belong to a PRS-able population, and therefore we offer this to you for free, and if you are not, that obviously is not going to be very inclusive, I would say. So, you know, I think the question needs to be really answered within the context, a sort of social-political context. So PRS in Estonia may be great. PRS in UK, in Italy, or in other large countries, most likely not okay.
Yeah, I mean, even in the US, where we talk about African Americans, that's like African Americans are one group where, you know, Africa has more genetic diversity in it than the rest of the world put together. So clearly it's not. So I think there's a lot to be done yet in development and validation of these scores before we see them in routine clinical practice.
Yeah, I would agree with that. We need a more diverse data set to work from to validate.
Or tools which are actually more or less susceptible to different performances based on ancestry. And there has certainly been a lot of statistical development in that area about developing scores which are less affected by ancestry.
Cool. We could almost do a human genetics session combined, but I mean it really shows the integration. So I'm not ignoring the upvotes, and we're at 8 for question number 1. So when you guys reach 10, I'll get to that one. But first I wanted to ask Clemens, what is your vision from the pharmacist and the drug maker for personalized cancer vaccine? And I mean, Matt did allude to that also. And how could they fit in practice? I mean, the dream versus reality.
Yeah, as I mentioned, our company and myself, I'm engaged in manufacturing. Now, you certainly have heard about the very high pricing of cell therapies. We are not talking now cancer in general, but cell therapies. When you see the price tags of those treatments, they're pretty high. Why are the price tags so insanely high? That is because the manufacturing is difficult. It involves a lot of logistics, it involves a lot of difficult manufacturing steps. Now the question is, what is my vision? What I see, what we have now the possibility with sequencing technologies which are developing, and in particular manufacturing technologies around mRNA vaccines, there is an opportunity that we can make those treatments affordable. Opportunity because we are not yet there. So if you ask me what are the manufacturing concept for these personalized mRNA vaccines, I'm afraid that I cannot say we are already there. I think it will take a little bit of time, but when you ask me for my vision, say in 10 years, I could well imagine that a decentralized manufacturing of mRNA vaccines is possible, be it in the clinics or be it in manufacturing sites which are really truly decentralized, where many hospitals have one center where they do this. mRNA vaccines do not require large bio tanks, it's rather small. So I think my vision is that in 10 years it is possible that we may get towards that. And that is only from a manufacturing perspective. There is a related question here. It's about reimbursement and other things and regulatory, they play a role. But I think we have a true potential to see it in 10 years.
Thank you. And actually that's going to lead us to the thumb up to 11, so thank you. In terms of the regulatory, so what are the main regulatory and reimbursement challenges you each panelist, and probably even more William, you face implementing precision oncology, and how do you navigate those obstacles? And I appreciate there are probably some differences country to country, so actually it would be really good to hear from each of you because you're each from a different country, and we'll see the spread. So if you want to start, maybe William?
Sure. So in the US, we have a break and fix healthcare system. It's very reactive. It's population scale, one size fits all. Insurance reimbursement is set up around that, or I should say the healthcare system is set up around that model of reimbursement, where nothing happens till something breaks, until the heart attack occurs, until the hip breaks, et cetera. So not a lot of energy toward being proactive and preventive. For our practice in our institute, fortunate to live in a part of the country where people are very interested in knowing their genetic risk and are willing to pay for it. So we don't do any kind of insurance reimbursement. Our hope is to demonstrate the proof of concept. We're still in the research phase, evaluating the effectiveness of this approach of PRS and using integrative risk scores. And does anyone know in the US how it is that they decide that they're going to pay for something? The insurance companies, anybody know? So is that another similar forum to this, and the CEO for United Healthcare, which is a really big insurance provider in the US. The way that they decide they're going to pay for something is not when there's clinical utility or it's a clear benefit to the patient or any of that. What causes them to reimburse something is when doctors are ordering it. So if patients demand it, doctors order it, ultimately the insurance companies will come around and reimburse it.
I can talk to regulatory challenges and a little bit on reimbursement. Regulatory challenge-wise, we will have to have working parties who can advise regulators what they should put forward as approval criteria. And these activities have started, and I'm confident that we will see a approval of a personalized vaccine already in the next 2 to 3 years. But in terms of breakthrough, where it will be that this is a standard of care, it's more my 10. But I think regulators are already aware of the challenge and have started the discussions. What do they require? In terms of reimbursement, and I let my colleagues speak to that, they are certainly more experienced in that. In Europe, we have something like which is called HTA, Health Technology Assessment. Now, health technology assessment for an individualized cancer vaccine is wonderful. I'm looking forward for the first HTA of NICE for personalized cancer vaccine. It will be hugely complex.
I can imagine.
Luca, any comment from Italy in terms of the obstacle for regulatory and payers?
Well, so first of all, I think this is a very complex question. So, the regulatory constraints are different depending on what you're trying to regulate. So, are you regulating a drug? Are you regulating a test? Are you regulating whatever else? So, the paths are complicated in all ways, but they're complicated in all instances, but they're complicated in different ways. In general, one has to understand that in Europe we have a very complex systems for a reason. Also, we tend to have a certain set of priorities that are in general modeled over our society, over a philosophy of society that is very different from what they have in the States. So the constraints are not just there to piss off people. they're there for a reason. But it is true that they are becoming more and more complex. So, for instance, in the diagnostic area, you're probably all aware of the fact that there is this new IVDR legislation that has been that was passed. But the interesting phenomenon is that the implementation, the hardwired implementation of the legislation has been progressively postponed every year. So every year they're saying, okay, fine. We're not ready for this. We move it for another year. Because it is true that going from a situation where there was some level of freedom on, every hospital was able in some way to provided that they could provide a certain set of tests, of parameters of quality, they were relatively free, especially in the field of genetics and molecular diagnostics, of coming up with their own PCR. You would have every hospital would have their own set of primers, for instance, for doing genetic testing. Now this is moving into a situation where you cannot do that anymore. But of course, this is creating a situation where a lot of players are not really willing to go to that length to develop something that then can be commercialized and used for diagnostic purpose. But as I was saying in my talk, I think someone has to do these things, because otherwise there's going to be an enormous amount of very interesting and very useful research that is only going to be there for research. And sometimes you are in this dilemma that came about before with the talks on the rapid diagnostics, no? Where the research associated information is valuable for the patient, and you are not in a position where you can use that information, and that creates this friction between what is legally right and what is ethically right, and you never want to be in that situation, and paradoxically, very often what one chooses to do is to not know, because otherwise you would be facing this dilemma, right? So there has to be someone who does the dirty job of, rapidly going from a very nice diagnostic test into a legally approved diagnostic test, because this is gonna, create a benefit for society, which is what you would ultimately want to have through science. So yeah, there needs to be probably more players that accept the risks of pushing this, unfortunately.
So some of us in the U.S. allow that to fall under the practice of medicine.
Exactly, but
So
we don't have that in Europe.
Yeah.
So sometimes we feel as, so we were a little envious with our American colleagues, where, as soon as there's a good new study on a new drug, they are able to provide it. Then, of course, you have a different type of inequality, because you're going to have one patient where you can provide the drug,
Sure.
and another patient where you can't provide the drug because the insurance scheme is different. But at least from the oncology, it sort of leaves the burden off the oncologist, right? I know that I can make this prescription, and I will do it if I am given the right framework for doing it. It's not my responsibility to choose whether I should make this prescription or not. Okay.
Yeah, we just, we're trained, the whole way through to just do what's in the best interest of the patient, and then, take it from there.
Yeah.
Matt, would you like to comment?
Yeah, well, so commenting on the NHS, it's by no means a perfect healthcare system, but hearing some of the problems that were raised there, actually it does have lots of features that are really good, that that we don't have some of those issues. So, for example, it bends over backwards to be equitable about access to diagnostic methods and therapies around the UK. So particularly commenting about NHSE, which is England, which is what I work within predominantly, it really does actually ensure that there is equity of access irrespective of geography, ancestry, socioeconomic status, etc. And that's pretty unique. So we have a really good regular review of diagnostic methodology that's available, that gets published in a national test directory that's updated every year. The testing that's listed in there is available irrespective of where you are in England. And then that's publicly funded. So again, basically no issue with access. So I don't think this is the forum for talking about the issues that the NHS does have in delivery, because it certainly does have those, but at least in those areas it's extremely strong.
But if I can ask you something, do you think that there is a bit of a tension here between equality of access and innovation, in a way?
Sure.
Let me give you an example, I would say, low-level example. Access to BRCA1 testing, right? Why is it done at least in Italy, I think it's the same in the UK, it can only be prescribed by a geneticist that first assesses your family history and whether you meet a certain set of criteria. But what's the reasoning behind that? Because you want to reduce the number of cases that you test, knowing that the likelihood of a positive result is low, right? But then, so you wouldn't test someone who's has a sporadic luminal breast cancer aged 65, right? But we know that there is a small percentage of those patients that actually are BRCA1 carriers. So the fact that you are reducing the access, you have some criteria for accessing that test, means that some people are not going to be given the access despite they may need it. Otherwise, someone would be able to simply choose whether to have a BRCA1 test or not, and maybe you would also intercept those rare sporadic tumors that don't meet the access criteria.
Yeah, so look, first up, it's not true that only clinical geneticists can order BRCA1.
In Italy it is.
Okay, so in the UK you can, and they also have population-level screening in high-risk groups.
Okay.
So it's actually much more widely available. But I guess you were just bringing that up as one example of what might happen.
Of course.
Ultimately, I think it comes down to a health economic question. If you've only got a certain amount of pound to spend, or euro, then basically it's obviously the most sensible thing to do to target that to the groups who are most likely to benefit. And for tests that are expensive, then fair enough. I think it's quite reasonable that we have criteria to decide who should actually get it based on an objective assessment of who's most likely to benefit.
Right. Thank you. Before we move on to a question from the audience, just because that's a massive topic there, I just wanted to give the opportunity if somebody has any comment or a very direct, narrow follow-up question on the topic of obstacle to access in terms of regulatory. Yes.
One of the questions in the on the list, assuming the cost would not be a barrier, what do you think it would take, and how long would it take for the predictive side of genomics to reach its full potential in preventative care?
So it's the question. So that was addressed to Matt on assuming that cost would not be a barrier. What do you think would it take for the predictive side of genomics to reach its full potential preventive care? But yeah, it's a very important one. Any comment first from anyone?
Yeah, I have a follow-up question.
Perfect.
Here. So we're talking about selecting what tests are going to be done. But if you use something like nanopore sequencing, my question is, why do you need to do it? You're sequencing thousands of reads on a patient, and you can look and see what he has. You don't need to select for what test you're going to do. Or am I getting the wrong picture here?
So is what you're proposing basically, I'm not sure I've understood your question correctly.
Let's say whole tumor sequencing.
Why not just
like
do
that.
whole genome sequencing of the tumor effectively?
So you can do it with technologies like nanopore sequencing.
Yeah, so look, we do a lot of whole genome sequencing in the NHS, predominantly currently through short-read whole genome sequencing, but the Cancer 2.0 program that I talked about, that's long-read whole genome sequencing. But the majority of cancer sequencing that gets done in the NHS is panel-based sequencing, and the reason for that is cost. So it still costs significantly more to do whole genome sequencing than it does to do a large-scale panel. That cost differential is obviously decreasing, and the other parts of the pipelines that are involved in cancer genomics personalised medicine are very similar, irrespective of if you do a large-scale panel or if you do a whole genome. So I think that ultimately whole genomes will replace panels, but at the moment the cost differential is such that that's not occurring.
There's another reason on that, if I can add on this. I mean, first of all, the topic we were discussing, and in general, there are two things that you may want to select for: who gets the test, and once you deliver the test, what do you put in the test? Okay, so first request, maybe the issue we were most discussing about was whether you should sequence the germline DNA of any cancer patient, whoever, with zero filters applied, and that is a selection on the patient. Okay, but you were asking on, once you decide to sequence, should you just sequence BRCA1 and 2, or should you sequence the entire genome? Now, there is, besides what Matt was saying, which is obviously I agree with, there is also an issue with the management of the information that you have, which is a huge issue. You only realize how big it is once you actually faced with the prospect of having back a whole genome sequencing analysis. So anyone here is going to have, if we sequence the entire genome, something that we may be interested in discussing with some specialist. It be the genetic Mendelian disorder or just some predisposition. And so sequencing the entire genome provides so much information that from a healthcare perspective, if you don't match it with counseling of some sort, it becomes unethical because you're giving this information to the patient without giving the patient the tools to understand what's happening. Sorry?
With the microphone, please.
But in the tumor, you're going to have that information as well, because you're going to, if you sequence only the tumor, you're going to have the somatic mutations, but you're also going to have the germline mutations. So, for instance, very often BRCA1 is another case of interest. You're sequencing the tumor, but then you find BRCA1, and you always have an ovarian cancer patients that get BRCA1 somatic sequencing. Any time that she gets a positive signal needs to go for genetic counseling, because then you have to establish whether that is inherited or not, and therefore whether there's family risk and everything else besides the treatment implications. If you now explode this to the entire genome, then of course it becomes a very difficult to manage problem.
So if I could just answer a couple of things. So one, the question of tumour normal versus tumour only is a complex question. Alona Sosinski, who's our head cancer bioinformatician, who's sitting down the end there waving her hand, has done a lot of work developing a tumour-only sequencing pipeline, which performs extremely well for whole genome sequencing and is likely to be implemented in the NHS. The second thing is about the value of doing whole genome sequencing in the general population. Genomics England definitely sees a future where everyone in the UK will have their whole genome sequenced. So we're currently doing a study where we're sequencing 100,000 newborns for picking up treatable rare diseases that will be complete over the next 12 to 18 months. And the belief is ultimately that will be offered as a routine service in the NHS. And then what we're looking to work on is sequencing older populations to look at, for example, polygenic risk scores and pharmacogenomic variation, again, probably by whole genome sequencing. And ultimately, we see a situation where everyone will have their whole genome sequenced. So at the moment, for me to get a single H allele typed in my local hospital is £60. So I have had quotes from whole genome sequencing commercial companies for $100 for a whole genome sequence. The costs are not that much different. Now, of course, that means there's still a lot of other things, for example, that Luca mentioned about how you manage the data, how you counsel people, how you use the data and things like that. But they're not so far off that this is science fiction.
Yeah, I agree with this, absolutely.
So I think that answers the next question in terms of the barriers outside of cost. Therefore, any question from the audience? Yes. Hold on 1 second for the microphone, please.
Just a quick question on the whole genome sequencing itself. How ready are we to actually interpret all of the information that you get from a whole genome? I mean, we still don't have population level data, and is that a larger problem than just the cost of sequencing at the moment?
So I'll take that one, and then the rest of the audience can have a go at that too. So I think the issue isn't so much the population level data, where there is actually now quite large data sets. There's 500,000 patients, 500,000 people from UK Biobank. There's 160,000 currently in our data set, and by 2026 it will pass 500,000. So there are pretty big numbers of patients that have been sequenced. Perhaps not in all ancestral groups, but certainly in people of European descent and in African ancestry, there's quite a bit as well, a lot in East Asians too. So I don't think that's the issue, but so much as just the ability to interpret the functional significance of variants in non-coding regions of the genome is in its infancy, and even for heritable diseases is really very limited. For cancers, I think basically it's like there's very little data because we just haven't. In most cancer clinical trials, the sequencing has not involved sequencing non-coding stuff, so we have no idea about whether non-coding genome actually influences cancer outcomes for cancer treatment outcomes. So it's a research area that needs a ton of work done on it, but it's clearly got a lot of potential.
Definitely early days.
All right, thank you. So we've been talking a little bit about speed earlier, but if we think about the overall patient journey, so the next question from the early symptoms, and we've heard that it's probably better to catch a patient there. What is the impact of the faster testing for the oncologist and for the patient? I mean, how big of an impact it can have? Because we saw this morning in Danny Miller's talk that actually the journey for a patient is not only the testing, there are multiple lag phases. So how do you see that adding value, and that it need to change, maybe alter a little bit the patient journey?
Yeah, well, I find that when patients understand their genetic risk, they respond quite differently to general advice. So when you give population level advice, don't smoke, watch this, watch that, there's, patient goes out in the parking lot and lights up. If you tell them that notice how your mother had breast cancer and your uncle had breast cancer, or not to say breast cancer, lung cancer or breast cancer, you may well have inherited some of that risk by virtue of polygenic risk scores. And you fold in those clinical risk factors. And I find that patients are much more responsive to lifestyle modifications and availing themselves to screening. So for example, in the US, low dose, do they do low dose CT scans for lung cancer screening? So what's the uptake here on that?
It's still a research project within the NHS.
Okay, so it's recommended by the USPSTF, the US Preventative Services Task Force, 5%, only 1 in 20 people that qualify for lung cancer screening get it. Now, if you tell them, or if you share with them the finding that they're likely at increased risk, the uptake goes up. They're much more likely to go get the screening. So,
I think that's the sort of thing that we really need evidence for. I love hearing examples like that, and I'm a believer in polygenic risk scores, but until you've actually got evidence that you can change behaviour, then it's not clear to me that
there are some, I don't know if I would call them well-done studies, but that has been looked at. I'm not just going off of my anecdotal experience, I'm sharing my anecdotal experience, but there is data that shows that people respond differently to that kind of inherited genetic risk than they do from population level. I don't know how good the studies are, but I would agree with you that in general, we're in early days on all this, and everything needs a ton more research, everything. But there's some exciting things out there. Also with the methylation risk, Dr. Laskin presented some information earlier this morning that in sequencing some tumors, they're BRCA1 negative, but the entire promoter site is methylated, so is that equivalent, and when can we start incorporating some of that thinking? And again, and I would agree with you, much research is needed.
Maybe one aspect, and I've seen that a couple of times in healthcare, when an innovation is introduced and it offers an acceleration, and the environment around does not change. All the innovation does not bring a lot, but the environment has to change. And what I've observed, these adaptations in behavior in order to leverage really the full potential, they take time. And I think on the question which was like, what potential does the personalized sequencing has to accelerate, it depends on how we are taking up the innovation and change the environment around it. It's a philosophical comment, but I've seen it a couple of times. Sometimes it takes longer to change the environment than to actually get approval for the true innovation.
So talking about that and innovation and where, pharma really changed the world, and most of us haven't heard about mRNA vaccine up until 4 years ago in a few months. But now, we saw this morning, they use nanopore sequencing to qualify the lots and even the products. So what is next for mRNA therapeutics beyond vaccine from the pharma standpoint, and maybe from a research standpoint from the other panelists? But Clemens, what are your thoughts on that innovative aspect?
I start, and we are here in oncology panel, so beyond the mRNA vaccines, which you have heard of, there are experimental groups working on the expression of antibodies and proteins directed against certain tumors. These companies, they're in early stages, so they are not yet in the clinic, they're in preclinical stages, but the vision of several startup companies, particularly in the US, but I have to say also in the UK, is that at one point in time you can bring in mRNA into your body, and the mRNA then will express, or your body will express with the means of the mRNA, a protein which is active against cancer. Again, this is early days, but it is a potential. So we have mRNA vaccines for oncology. We have mRNA treatments which may express proteins against cancer. And beyond that, I think the mRNA vaccines have already an established place in infectious disease vaccines, and beyond infectious vaccines, infectious diseases, there are vaccines currently in place for viral infections which also have a certain impact on tumors. So these three areas, I believe you will hear more about mRNA therapeutics and vaccines.
Cool. Thank you for sharing the insight. Any comment from the panel?
Well, so as you mentioned, there's a large-scale program being run through the NHS called the Cancer Vaccine Launchpad in the UK that's running clinical trials of personalised cancer vaccines, currently predominantly with BioNTech and Moderna, but other companies lining up to do that as well. So this has obviously got a phenomenal amount of potential. Currently, there's only reported clinical trial data that I'm aware of on melanoma, but it'll be really interesting to see whether it works for other cancer types as well. If it does, it's going to mean that not only are we going to have a massive surge in mRNA vaccine production, but also that healthcare systems are going to have to be able to do cancer profiling comprehensively and extremely rapidly. And although the UK has a pretty good cancer genomic medical service, it's a challenge for us. So I think that for some other jurisdictions, even in the developed world, that is going to be a real challenge for delivery.
Thank you. Any question from the audience? We have about 6 minutes left. Yes.
So would you recommend I sequence my genome, and because I would have the resources time to have a look at it, or did you, maybe if I may ask, did any one of you have your genome sequence to see what's going on, or what you can do to prevent cancer risk, or reduce your personal cancer risk?
Who wants to go first? Don't jump all at once.
Did you have your
I've had mine sequenced. But
I've had that sequence. I believe in it. I believe that you want to understand your monogenic variants. The thing that I would say that I would want to leave the impression is I've done about 150 patients, done their whole genome sequencing and put through this analysis I kind of described. And when I started, I would have been excited if I saw a 15 or 20% of the patients that had some significant impact. Honestly, and again, anecdotal, I am keeping data, but the amount of unrecognized risk that's out there, and maybe not as much for cancer, but in the U.S., for sure, heart disease. You know, when you, I can't tell you how often, is the most common scenario is that someone has no idea they're at risk for heart disease. For some reason, their father died in their 50s or 60s of heart disease, their uncle on their dad's side also. and their LDL is running around at 150. Their apolipoprotein B is high, and they think, and because they run 5 miles 6 days a week and eat a Mediterranean diet, which I really endorse, that they're safe. And you do the polygenic risk score and you do an integrated risk score, they don't appear safe. What do? Well, we send them for a coronary CT angiogram. I know you can't do that on every patient, but more often than not, in that scenario I just described, they have significant disease. And they had no idea. They're 55, 60 years old, had no idea. And in that particular case, you do aggressive risk factor reduction, and you can change their likely healthcare trajectory by doing that. So I've seen pretty amazing successes. Again, anecdotal, and again, those studies need to be done. Yeah, so I recommend it for everyone, and especially at that cost. It can be done relatively cheaply in the hundreds of dollars, not thousands of dollars, not tens of thousands, not 3 billion like the first genome. It can be done usually for under $1,000, and usually in a few days if you have something like a nanopore flow cell to do it. But even without that, it can be done in weeks, and this information can be life-saving. I've seen it.
Matt?
So I had mine sequenced in 2014, and to my surprise, it showed me I carried hemochromatosis variants. So it was personally relevant, and it was relevant for cascade testing, and there's no way I would have been tested otherwise. So personally, I thought it was brilliant. I think that ultimately, once the ability to report these becomes better developed, that it will become very useful at a population level. Is it there right now? Arguable, but I certainly think in the next 5 to 10 years it will be.
Maybe one quick final comment from the panel, and then we're going to have to wrap up.
I just wanted to challenge the positivity again towards getting the genome sequence, because I think I am the one in the panel who's regularly facing patients. And one thing that I can say is that people react to the same information in very different ways. So the same thing that would be useful for many of us would be deleterious for many other people. Not everyone reacts to statements about their fate in the same way. And I think the question that you're posing is one of the most important questions that we probably have nowadays in our life, because it's a little bit of the equivalent in 2024 of an ontological question that has been in the mind of mankind forever. So if you knew, when you were going to die, would you change your behavior? So people would answer to this in very different ways. And I think that it needs to be, it has to do a little bit with education that you have at school. Yeah. It has to do a lot with how you face probabilities, risk, whether you have a good mathematical literacy or not, and you're able also to rationally react to things that may be negative for you. So some people would, it is a very similar dilemma for screening as well. There's lots of people who are offered screening, but they just don't do it because they don't want to face the possibility that they have to take decisions. So they let fate take decision for them.
You hear this amazing science. I would argue that in this day and age, you want to know. You want to know your risk.
Well, you would want to know, but not everyone would want to know. That's the point.
Yeah.
So that's a vast debate, and I think what it really showcases, and we're running out of time, so that's not that I want to cut short, but putting the patient first is basically a patient's interest. So having a patient as a North Star. We've discussed a few topics. A lot around PRS, polygenic risk score, accessibility, innovation from new and future therapeutics. So I had a great time. I hope it was the same for you. We don't have any more time, though. That being said, I'd like to you to join me in thanking our panel once again for such an exciting and vivid, insightful discussion. So. So we are now heading into the final break. If you have not already, please do visit the product tables in the live lounge, where our teams are ready and waiting to answer any questions you may have about nanopore sequencing. At 2:50, so pretty soon in the Secret Cinema, you can watch a pre-recorded presentation from last year's nanopore community meeting using nanopore sequencing to analyze inherited retinal disorder. Alternatively, 5 minutes after that, so at 2:55, you can join the Oxford Nanopore team who will be demonstrating the use of the AP2M analysis platform for clinical and biopharma application. Finally, this is also your last chance to vote for your favorite posters. The winner will be announced at the last session of the day. You can do this by scanning the QR codes in the poster hall or in the event app. After the break, we'll be back in the auditorium downstairs for the final session of London Calling 2024. Thank you very much, and see you there.